Hi guys, this is Caesar with Nursing School Made Easy. Today's topic is going to be on inflammatory bowel disease, or IBD. Now this lecture is going to be a little bit long because I'm going to combine both ulcerative colitis and Crohn's disease together. I'm going to compare them side by side. Okay, so again, inflammatory bowel disease. Now, first thing you have to know is that this is an autoimmune disease. Again, it is an autoimmune disease, which will dictate a little bit of the therapy later on. So let's get right into it. Again, inflammatory bowel disease is an autoimmune disease. Let's start off with Crohn's. And I misspelled that. Now, excuse me, you have a lot of similar pathologies occurring in both. Both of these occur typically in the teenage years to about the age of 30, mid-30s or so. Okay, both Crohn's disease and ulcerative colitis. And in Crohn's, one of the things that makes Crohn's very, very different from ulcerative colitis, and make sure you know this for your nclex, is that Crohn's can occur anywhere in the GI tract. So this can occur from mouth to anus. Okay, again, it can occur anywhere in the GI tract. Now, most of the time, it'll occur in the terminal ileum and colon. Now this is very important here because a lot of vitamin B12 or cobalamin absorption occurs in this area. So if this area is problematic, then you have decreased cobalamin absorption. Okay, so make sure you understand that. Now, in Crohn's, there may be what are called skip lesions. So let me draw out a little bit of anatomy here. So here we have a person, eyes, mouth, neck, shoulders, so you have esophagus, and as always, stomach. It's going to turn into lots and lots and lots of small bowel. Then we're going to go into the large bowel. Something like that, okay? So, like I said, in Crohn's disease, you may have some skip lesions. So this area here may be affected, and then maybe this area here may be affected, and this area here may be affected. Maybe even by the esophagus, maybe that area might be affected. So again, these are what would be considered skip lesions. Okay, so that makes Crohn's very different from ulcerative colitis. Now again, I said that this can occur anywhere from mouth to anus. So typically with these patients, surgery is not always done. That's a kind of a last resort, because imagine if this patient is having surgery, they'd have to get surgery here, 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 and here. So again, surgery is more of a severe situation type of thing. Now, these lesions will cause a cobblestone appearance of the bowel. Yeah, know this for the nclex. Now, sometimes these areas of inflammation are going to become so inflamed that they will cause an obstruction or a stricture. Now this stricture is going to cause an obstruction, so maybe even constipation in some cases. Now one thing that you have to understand about Crohn's disease is that all layers of the bowel are going to be affected. They're the innermost layer, the tunica intima, media, and then the outer layer will also be affected, okay? So you might have an infection that goes through all layers of the bowel. So if you could imagine that this is a layer, the entire bowel may be affected, which allows all that fecal material to get out. If that occurs, you will most likely become infected. You may suffer with something like peritonitis. Okay, now again, this is different from ulcerative colitis, because in ulcerative colitis, you do not have all of the layers being affected. So again, this is due to perforations. Now again here, we saw how some of these, this inflammation can lead to destruction of the bowel. Well, for example, in women, right down here in the rectal region, you're also going to have the bladder, right? And in women, later on, you'll end up with some problems in the vagina or with the bladder, because here I talked about how there can be some perforations. Well, if the perforations occur in the area, for example, where the intestine and bladder sit next to each other, there could be a perforation that leads fecal material into the bladder or into the vagina. So you can actually have some fistula formation. Okay, so this would lead into the bladder or into the vagina, and with these patients, especially female patients, they'll run into a lot of UTIs. So you may see some fecal material in the urine, extremely foul-smelling urine. Again, this is more likely with Crohn's disease, because all portions or all layers of the intestine are involved, which again allows for perforations to occur, and those perforations may lead eventually to the formation of fistulas, more importantly in the bladder and in the vagina, causing again UTIs and extremely bad smelling urine. Now that is in Crohn's. So now let's talk about ulcerative colitis. Trying to focus this in on the camera here. It's not working too good. So again, in ulcerative colitis, this can occur between teenage years to about roughly 30 years of age, just like in Crohn's. Same thing occurs in ulcerative colitis. Now, in ulcerative colitis, this pathology or this disease typically occurs in the rectum and will work its way up into the cecum. Now, in Crohn's, we said it can occur anywhere. Well, in ulcerative colitis, it may start down here and begin to work its way up and come to here. So it's a bit of has more of an organization. Okay, this part may be affected, then it might move its way up. It will not have those skip lesions. So again, this is one thing that sets it apart from Crohn's. So again, this will start in the rectum and most likely end in cecum. Now we talked about how in Crohn's, all layers of the intestine are affected. In ulcerative colitis, only the inner and mucosal layers are affected. So yes, sometimes perforations may occur, but it is very rare with ulcerative colitis. And for that reason, fistulas are also rare. Now, in Crohn's, we talked about a cobblestone appearance of the bowel. In ulcerative colitis, you're going to have pseudopolyp formation. So these will appear like tongue-like. Sorry about my spelling. Tongue-like projections. Okay. I'm having a hard time to write both of these things in here. But again, this is what sets ulcerative colitis, these tongue-like projections versus the cobblestone appearance in Crohn's disease. Now let's talk about some signs and symptoms. Let's focus on Crohn's first. So number one, diarrhea, and this will also occur in ulcerative colitis. Number two, bloody stools. Again, this will also occur in ulcerative colitis. 3, weight loss. 4, abdomen pain. 5, fever. Now this is a biggie. Colicky abdomen pain. Now there is another instance when you would have colicky abdomen pain. Do you remember that? 7. Now we talked about bloody stools, and yes, it is present in Crohn's, but rectal bleeding is not as common as it is in ulcerative colitis. Anemia can occur. Now, I talked about this briefly. Again, cobalamin is, or vitamin B12 is absorbed in the ileum. And we talked about how the ileum can be affected. So if the ileum is affected, you will not be able to absorb vitamin B12 or cobalamin. So you'll have cobalamin deficiency anemia, or vitamin B12 anemia. So this is a more specific type of anemia. Now these patients are at high risk for developing small intestine CA. Now, in ulcerative colitis, again, you're going to have diarrhea, you're going to have bloody stools, you're going to have weight loss, and you're going to have abdomen pain. But there's a big difference here. Here you will have bloody stools. But you may have up to 2 to 20 bloody stools per day, depending on the severity of ulcerative colitis. So that is a huge difference. So again, you'd have between 2 to 20 bloody stools per day. So bleeding out that much is going to cause anemia. Okay. So also you'd have fever, malaise, especially if you're going to feel weak and tired if you're losing that much blood and if you're anemic. Weight loss. Big one is dehydration. If you're losing all those fluids, you are going to be dehydrated. Again, if you're going to be dehydrated, anemic, you will have an increased heart rate. Now these patients are at high risk for colorectal CA. Because remember, ulcerative colitis affects the colon, rectum to cecum, that's colon, as opposed to Crohn's. This can occur anywhere. So your small bowel is affected, which is why these run the risk of small intestine CA. That's a big difference. Now, let's talk about some diagnostic studies. You're going to look at your lab values. And those lab values you're going to have, or you're going to find that your CBC, especially your red blood count, your hemoglobin, hematocrit, might be decreased. Your WBC will be increased. Now why? Well, anytime you have an infection, your white blood cell should go up. Okay? So that is why your WBC would be increased. Now you're having lots and lots of stools, lots and lots of diarrhea. So therefore you should expect that your electrolyte levels will go down. That includes your sodium, decreased potassium, decreased chloride, decreased magnesium. Okay, those are some of your lab values. Another thing that you'd want to look out for is hypoalbuminemia, or decreased albumin levels. That's what you would find. Again, decreased hypoalbuminemia. You would also find elevated ESR levels. Erythrocyte sedimentation rate. Now this will also be elevated in something else like arthritis. But which type of arthritis? If you don't remember, refer back to that lecture because I guarantee you'll see that on the NCLEX. But again, here your ESR levels will be elevated, and that is indication of chronic inflammation. Number 4. Another thing to help diagnose this would be a sigmoid oscopy or a colonoscopy. Now, once they do the sigmoidoscopy and colonoscopy, they will most likely also do a biopsy of that area. You can also do stool cultures. You also want to assess that stool. Is there a lot of blood? Is there a lot of mucus secretions with it? And something else called a double contrast barium enema. And this will be done in the radiology department. Okay, again, double contrast barium enema. They'll inject both. They may inject something like barium, hence the name barium enema, into the colon, and they will also put air in and help distend the colon so that the radiologist can get a better look and see if there's any diverticuli, any polyps, any ulcerations. And again, this will be done in the radiology department. Now, what are some interventions for your patient? Number 1, you give the aminosalicylates. or 5-ASA. Okay, again, these are the aminosalicylates. Now what these do, these decrease inflammation. Examples of these medications would be something like azolfidine, dipentum, and azocal. Now with these patients, you also want to tell them to take folic acid on a daily basis. Okay, again, these are to decrease inflammation. Number 2, antimicrobial. Especially if you're running the risk of a perforation, you have inflammation, so you have the high likelihood of infection, so you're going to be giving an antimicrobial. So these are to decrease infection. So you may give something like Flagyl, Cipro, or something like clarithromycin. Number 3, corticosteroids. Now again, these are to decrease inflammation. Examples of that would include prednisone, hydrocortisone, pretty much look at your ONE. Anything with ONE will be a corticosteroid. Now, you're going to also have to tell your patient that this is going to decrease their immune system. And they must know that, because you're going to have to give them other education on that. Okay, so realize that if you give a corticosteroid, yes, it's going to decrease inflammation, but it's also going to suppress your immune system. 4, immunosuppressants. Now, as the name implies, you're going to hopefully bring down their immune system. Now, in the very beginning, we talked about how this is an autoimmune disease. Their own immune system is attacking their body. So that is why this is given. It's given in hopes to knock down their immune system to stop that inflammation. But again, you run into other complications, because this makes it more likely for these patients to suffer from other types of infections. So an example of your immunosuppressants would be something like Murin or methotrexate. And I'm just giving you a few so that hopefully if you see these on the nclex, you know what they are. 5, your biologic therapy or targeted therapy. Again, these are meant to prevent inflammation. An example of this would be Humira. Okay, all these medications are geared towards decreasing inflammation or suppressing your immune system, because again, it is an autoimmune disease. continue with our interventions here. Now, depending on how severe the ulcerative colitis or Crohn's disease is, surgery may be required. So let's move on to number 6. In 75% of patients with Crohn's disease, surgery will be required. Again, that is in about 75% of patients suffering from Crohn's disease. But one thing that you must know about Crohn's is that it is a recurrent disease, which is why I tell you that it's kind of a last resort, because yes, surgery can be done, but the inflammation will occur again. Again, it is a recurrent disease, and typically the disease will reoccur at the surgical site. So that is one thing to keep in mind. Now, with ulcerative colitis, about 25% to 40% will require surgery, as opposed to the 75% for Crohn's. Now, typically, again, in ulcerative colitis, this is a problem of the colon. So we'll get into that here in just a little bit. Now just think about this. The colon is affected, and if a surgery is performed, typically what will happen is the colon will be removed. So the patient may have a colectomy. And they also have, due to the colectomy, they may have an ileostomy. Now this may be permanent or not, depending on the surgery that is performed. And for example, something like a total colectomy with ileoanal reservoir can be performed. Now, what is that really? Let's go to my fancy drawings again. Okay, we're going to have esophagus here, stomach, and then we're going to have the duodenum, rest of the small bowel, jejunum, and then ileum, right? That's your basic anatomy. And then remember, that ties into your colon. I'm oversimplifying, of course. Colon's going to come up. So this would be right side of patient. This would be left. This would be ascending colon, transverse, descending, sigmoid area, and rectum. And then followed by the anus. So in an ileoanal reservoir with total colectomy, this entire portion, let me switch things around here. This entire portion of bowel, large bowel or colon, is going to be chopped off. This, of course, will be done by the surgeon. So this will all be removed. So if you could just imagine, I'm going to yank that off. And all you're going to be left with is the small bowel. Now what will happen is they will redirect this to come down here. And that is your ileoanal reservoir. So So the ileum will be connected to the anus, hence ileoanal reservoir. And again, the entire colon is removed. Now you're able to do this with ulcerative colitis because, again, remember that ulcerative colitis affects the colon only. So if you remove this, you also remove the chances of that patient getting colon CA. Okay. So that is what a ileoanal reservoir is. Now, this is one option. The other option would be to just close this off and then again have an ileostomy put in place. Okay. Now, in the ileostomy, this would be connected to the outside of the abdomen. And so this was just dumped into an ileostomy bag. Okay. Now, if there is something else that is talked about in some of your books, and that's a Koch's pouch, we won't really get into that because that's very, very rarely used. So maybe some of you will see it in your book and maybe some of you won't. Now, if your patient is going to undergo surgery, you can do all of your post-op assessments. You're going to check the site for hemorrhaging, for obstruction, making sure that there is stool coming out. You're going to assess for abdomen sounds returning. And also remember that these patients will, let's get to number 8, may have an NG tube in place. Again, the NG tube is going to come in. It's going to suck out the gastric contents so that the bowel can rest. Let it heal. Okay? So that is the purpose of an NG tube. Now again, you're going to make sure that at some point there are bowel sounds present. Also, if there is an ileostomy in place, you want to make sure you clean that area with mild soap. Make sure that it is the appropriate color. If not, you need to report that to the physician immediately. Another thing that you want to tell your patient to do is to avoid smoking. And in some instances or some cases, TPN may be required. Also, we talked about this briefly. In some instances, your patient may require cobalamin, vitamin B12, supplementation, and also iron supplements if they're suffering from iron deficiency anemia.